Hello, everyone, and welcome to the Diversity MBA Smart Series. This webinar, focusing on health equity. I am Jackie Burgess-Bishop and have the privilege of serving as the CEO for the National Kidney Foundation of Illinois, and for this webinar, serving as a moderator and a participating panelist. With that, I would just like to provide the titles of the other participating panelists. Number one, Dr. Milda Saunders, who's an associate professor at the University of Chicago Medicine, and Deborah Grimes, RNJD, who is the Senior Vice President and Chief Diversity Officer for Ochsner Health. So we have represented on the panel, as stated, a Chief Diversity Officer and leader in health system across multiple markets, a medical leader engaging in and integrating nationally funded patient care, research, medical education, and outcomes, and a health leader with experience in multiple segments of healthcare at a population health level and direct community engagement and partnerships. Two of our panelists are licensed medical and clinical professionals, and one of the two that were previously mentioned is also an attorney, and all three of us are committed to health equity. So as we are here this afternoon to discuss health equity, identify initiatives of impact, and the future of addressing health equity in the changing trajectory of healthcare and health industry for at-risk populations. So what I'm going to do is ask each panelist to provide a brief background so that you can get to know them better as we launch into the webinar. I think I'll go ahead and start with Deborah.
Good afternoon, everyone. And Jackie, thank you so much for the kind introduction. And I am excited to be able to participate in this webinar today. Just a little bit about my background. I started out my professional career as a nurse. I was a labor and delivery nurse and delivered a bunch of babies and did a lot of work clinically on the inpatient as well as outpatient, did research at an academic medical center in Birmingham, Alabama. I also, about 7 or 8 years into that tenure, went to law school at night while still nursing during the day, and was fortunate enough to work in the general counsel office and also worked as a healthcare administrator responsible for quality and patient safety, and then ended my career there, starting the first as the Chief Diversity Officer. Personally, I'm also the mother of two. I've been married to my wonderful husband for 32 years, and I'm also the grandmother to my first grandson. So life is really good, and just excited about and passionate about the work of health equity.
Thank you very much, Deborah, and want to advise all attendees that you can enter your questions into the chat, and we will take questions during the webinar. So want to move now forward to Dr. Milda Saunders. If you could give us a brief background, thank you.
Sure. Thank you so much. Thank you so much for having me. I'm Milda Saunders. I am a physician, an educator, and a health equity researcher. Most of my interventions focus on research and interventions to improve the outcomes for individuals with chronic kidney disease, usually minoritized individuals. I am a lifelong Chicagoan, although I left for 10 years to get my training, college, med school, and PH on the East Coast. I also spent some years in Washington, D.C. working as a policy analyst for housing and community development. And so a lot of my interest in disparities, particularly healthcare disparities and how neighborhood impacts that, sort of stemmed from growing up in Chicago and seeing that despite the many opportunities in the city, those opportunities were not distributed evenly in different neighborhoods, and the neighborhoods were not randomly assorted with groups. And so thinking about how location really impacts people's opportunities for wealth and education and for health was a focus of my policy career, and then is also a focus of my clinical research work.
Thank you. Thank you very much. I always call you Dr. Milda. So thank you for that and sharing that engagement that you have. Just, very briefly on myself, I've had an opportunity. I've been in healthcare leadership roles across multiple segments of the industry, from the perspective from population health through community level engagement, behavioral health, occupational health, working in the cancer space, working and the HIV space when I was doing consulting, and just, again, always committed. What I'd like to say with this is to pivot back to Deborah in terms of, and the other part of my background, I have married and have 2 adult children. All right. So with pivoting back over to Deborah, in terms of what in your background and experience contributed to your path of engagement in health equity?
That's an interesting question. As I reflect on that question, I would answer it in terms of, it really starts with why I chose to be a nurse. And I grew up in a small town called Anniston, Alabama. And I started to notice that my family members, it was the tale of 2 very different situations. They either lived to be over 100 or they died in their 60s. And the differences in that was really how early they developed disease like diabetes and hypertension. And I saw my grandmother struggle with that, and I lost her at an early age. And I started to get intrigued about, how can we make people healthier? And that's why I went into healthcare. And that's why I wanted to be a nurse. And then I think about, in terms of how I approached nursing, was all about, I wanted my patient to have the very best outcome. And when you're the nurse, you can impact that outcome or that experience day by day. And being a labor and delivery nurse, I really understood early on that different cultures approach the birthing process very differently. And if I was going to reach that goal of them having the very best experience, I had to understand not just about the patient, but the patient's family and the patient's culture. And I was 22 years old. And because of that commitment of wanting the patient to have the best outcome, just got me into understanding these cultures and understanding a little bit how I had to approach pain management, how I had to approach whether the physician was a male or a female, if my patients had a different religious background, like Islam. And so it was all of that that led me to where I am today. Some of my earliest leadership roles had to do with working in quality and patient safety. Well, when you fast forward to leading health equity at Ochsner Health, we know that you cannot be committed to having excellent outcomes and still be okay with having health disparities. Those 2, and no institution, no healthcare institution will say, you know what, quality doesn't matter, patient outcomes doesn't matter. No, we all say that we're committed to having excellent outcomes. We are committed to having great quality results. We want to have patient safety. Well, the Institute of Medicine told us, if we're going to do that, we have to address health disparities. And so that's a long way to say everything about my journey has been about making sure that every patient has unique care and has the ability to have the very best outcomes possible. And over that 30-year journey, I've decided that the way that I want to do that is to really work on diversity, equity, and inclusion. And I'm fortunate enough to work at Ochsner Health, where I get to do that every day.
Thank you. Really a fascinating and an impactful journey. And thank you for sharing that. It's interesting when you look at chronic conditions, you look at some of the factors, across at-risk populations that often are under-resourced and also have and encounter a number of social issues, or we call them the social determinants of health and social factors. You look at a chronic condition such as kidney disease, which we are working with, in our case every day, and the lack of awareness. And what we also observed is, on one hand, there's a lack of awareness, and on the other hand, there's a degree of acceptance. Every time our team, be it at a population health level, be it speaking with researchers, but particularly when we're in the community and we work, with across multiple communities and cultures, and we often come across this type of response. Oh yes, my aunt, my brother, my parents, other, relatives, friends, colleagues, coworkers, they have kidney disease, they're on dialysis, and this kind of almost a matter-of-fact statement. So we go from one component of looking at a total lack of awareness of the 1 in 3 at risk, the 37 million, in our case, on a national level, that have CKD, the number of patients that are transplanted, of which minority or so populations are underrepresented. And I'm going to pivot quickly over to Milda, to Dr. Milda, to talk more about, her area and what she's been, the impact she's had. And so when we talk about that, we're focusing on kidney disease and that awareness. And even because in my career, I've worked in other sectors or other conditions, those that have, I would say, a higher level of knowledge, so for us, many people are not aware that there's 5, stages of kidney disease. They go, there are, and then there's other issues that are encountered in terms of different measures, like, EGFR, and I asked Milda to talk about that a little bit, in terms of, those types of diagnostic tools that really have impact, and there are barriers to care, both on the diagnostic side for kidney disease, as well as people being listed at the appropriate time on the transplant list. So we see that, in the kidney space, we can talk to, our colleagues, and we also know clearly uncontrolled diabetes and hypertension lead to kidney disease, but also amplify cardiac disease. And so with that, what is our charge? And we take our charge seriously to changing that trajectory through education, prevention education, through screenings, supporting research. So with that, we know, and as you indicated for Ochsner on a multi-state level, for us, we are the affiliate, the Illinois affiliate of the National Kidney Foundation. So on statewide, as well as looking at a national level, how this change has to come. So what I'd like to say, Milda, Dr. Milda, in terms of, that was my lead into you, from the perspective of, and as a physician, a researcher, clinician, what are some of your thoughts in terms of looking at health equity? We talk about equity, equality, belonging, a lot of those factors.
Okay, thank you for your setup. So I think first, we'll talk with the larger structure. So you mentioned the social determinants of health. And so health equity should not just be within the sphere of clinicians. It's not even just in the sphere of the healthcare system. And so we have to sort of take a step back and think about what we can all do in terms of improving life chances for people who are underrepresented or minoritized in terms of education, in terms of housing, in terms of wealth building, in terms of safe places to play, opportunities, because all of these things influence our health. And some people say that those factors are about 40% of our health, right? And so we're not even, that's before you step foot in a doctor's office, come near a hospital. Also the physical environment. Do you have sidewalks to walk? Is your water clean? Do you have lead in your water? All of those things. And, you know, the health behaviors that you get, as you mentioned, from the people around you. Is it okay to smoke, or is that something that's just not done? Do you drink? Do you, do you have healthy, sort of long-lasting relationships? So those are all things that you haven't even stepped into the doctor's office yet. And that's a lot. Do you go out and walk after dinner, or do you sit down and have dinner as a family? Those are things that are, these habits are sort of built by families, but are certainly influenced by a lot of historic and economic forces. So it's not just family. Now you've walked into the healthcare system. So within the healthcare system, I think it's important that people have access, so that our insurance, but that people are insured or nationally insured and allowed to have access to care. But then there has to be care that is nearby, that they think is available to them, so that people feel it's close, hours work, they feel welcome. It's a safe, sort of welcoming space. And that's, the physical space and the front desk. And then you see the clinicians, and making sure that, as you say, that we're doing the blood tests to look for chronic kidney disease and other illnesses, that we're doing the urine tests to check for albuminuria. And then once we have that information, we have to then tell the patient, hey, did you know you had chronic kidney disease? Hey, did you know that this can be delayed or prevented by controlling your blood pressure, by, losing weight, by working on your blood sugar, by stopping smoking? So, we have to have that information as clinicians and share that with our patients. And then also sort of believe that they can make a difference and help them in that. And so I think it's sort of a really complicated thing. And then once you get to, dialysis and transplant, sort of advocating for patients, connecting them to resources, and sort of coaching people through the process. Because, while transplant is the best treatment for chronic kidney disease, end-stage kidney disease, it requires a lot of patients and families to get there. And so we need to make sure that people are aware that that's an option. And that people who most need it are aware of that and have sort of some coaching and support to get through that workup process and through the finish line. And then I would be remiss if I did not talk about living donation. We know that in a lot of areas, including Illinois, it takes, even if you go through that long process to get on the wait list, you still are waiting 5 to 7 years. And if you have friends or family members or people in your parish or sorority who can consider donating a kidney, that cuts that time dramatically and reduces your health risks and improves your quality of life. So I don't know, Jackie, did I miss anything you want to?
No, I think you covered, quite a bit, and really you led a pivoting question, or a leading question I want to circle back to Deborah with. And in terms of, we've just quickly addressed, from the prevention all the way through end stage and then transplant. On a broader scale, Deborah, what is the role that you have experienced, see, and what Ochsner is doing in the space of prevention and early detection of kidney disease, other chronic conditions, attempting to even address behavioral health, mental health, those situations that are impacting, our communities.
Yeah, I mean, I think, she just set the tone very nicely about what needs to be done. And then you think in terms of a healthcare system like Ochsner, which is located in the Gulf South, which, if you look at the health rankings, we have so many disparities in our region. And I think coming to terms with how it's such a, it reaches across so many different sectors. And it's first really understanding the audacious process of being able to address all of that. And I think addressing it from a humility standpoint, and then figuring out from, it's two different issues. So the healthcare system is designed to potentially create healthcare disparities. So we have to internalize that. And then we have to figure out what metrics are we going to follow from a demographic perspective to monitor that. Because a lot of healthcare systems are built off of unconscious bias. They're built off of things that we're not consciously trying to harm patients, but if you don't even think about the possibilities of that, you could be inadvertently taking a situation where there are real equity issues, social determinants of things. We just identified that 80% of what's causing a patient to be unhealthy has nothing to do with what a healthcare provider can do in a 15-minute visit or in a 5-day hospital stay. 80% of what's leading you to be unhealthy, we do not control, okay? But there's that 20% that we do control. So as a healthcare system, we have to own that. We have to look at our outcomes, seeking out the possibility of unconscious bias or unconsciously harming patients, and then go where the data takes us. So that's the 20%. But then as an organization, what Ochsner is doing is saying, we still don't want to forget about the 80%, because our end goal is for everybody to have the very best outcome. And we know that if we just focus on the 20%, that's not going to happen. So then we say, what can we do about the 80%? Part of it is recognizing that we need to do something. The second thing is building on that trusting relationship with the communities that we serve, starting a conversation, showing up, partnering with government relations, partnering with education, partnering with food insecurity, just trying to show up as an organization and help where we can, partner where we can, volunteer in the community. Part of it is education and awareness. That's why we work with things like the Urban League of Louisiana. We show up at health fairs, because a lot of it is eliminating and creating this awareness that what kinds of things can you do to be healthier? What are the barriers to doing that? And creating this community partnership where everybody's working together to address those things and finding like-minded organizations to partner with. So I think that's how Ochsner is approaching it, is we have to work on that 20%, which is the health disparities, or identifying the things that we may be doing that we need to look at differently. So that's one aspect. And then the other is, how do we partner and have a health equity strategy that's community focused, working with partners like Xavier University. We have our OxyHer, where we're looking at research, health disparities research. We're looking at how do we get more healthcare workers, physicians, nurses, APPs, PAs to look like the community that we're serving. And that starts upstream. That starts working with our middle school and high school students to get them interested in healthcare and removing those barriers to them being able to do so. So it is, you have to have a very broad strategy, but it really starts with that awareness of the situation at hand, and then coming up with, as an organization, what types of things are you going to do to be able to address all of that?
Thank you. And you're absolutely correct in terms of the breadth of the strategy and the relevance and importance of partnerships. And I think one thing COVID taught us all is in terms of entities that were competitors recognized that they needed to have alignment and to work together, and the benefit of working together. And hopefully that stays with us. We don't regress. I'll put it, regress back to former silos. But there's been a number of collaborations that have been established, across the country that are demonstrating like what Ochsner is doing and making that difference in the metrics. What I like to do in terms of, and want to ask Milda, Dr. Milda, because it was something Deborah said that, that 80-20, and with that 80%, once the doors are open, resources are available. How do we address empowerment so that people feel empowered to make a change? So, for us, we have a program that we call Take Charge that, teaches and works and educates, patients and those impacted on how they can take charge of their health. What are your thoughts on that?
Yeah, that's a great question. I think it, again, it's from both sides. And so I know that, I, in my work, deeply believe that giving the information to patients, both helping patients, individuals in the community understand what their numbers are, what words we're using, what those words mean, understand also importantly, the long-term implications. So people don't care about A1C, but people care about strokes and heart attacks and being able to have all of your limbs, being able to see your grandkids. People care about that. So not only translating the medical language, but translating that into meaningful outcomes for people, I think is important so that everybody's on the same page. We have the same goals. The other thing though, is in empowering patients is information, but we also need to have the right response. And so if patients come and they ask us questions, they are potentially empowered, but then they get no response, they get no information, they get no change in the questions that they have or their requests, then they don't do that again because they've learned, we've taught them that doesn't work. And so I think we need to both give them the language and the skills, but then I think as a healthcare system, as clinicians, we need to respond appropriately.
Great, thank you. Deborah, I'd like to ask you that, that same question in terms of that empowerment part and the importance of that.
Yeah, I agree wholeheartedly with what you just said. And I think we also need to take into account that empowerment can only come, that's a partnership, because there is a fear to coming into the healthcare system. And we need to own that, and we need to build trust. One of the things that we've done is we've hired patient navigators. And these are not clinicians. They're lay people. They could be social workers. They could not be social workers. And we train them. We make sure, that they look like the patients that are coming in. And they establish a rapport, a trusting relationship with the patients and the patient's family. And they meet them where they are. and they have an agreed upon relationship that my whole role here is to help you to get the questions answered that you need, is to get you to walk away with a treatment plan that you understand and that you agree with. And if there are barriers, my role here is to remove those barriers. Because what we've come to understand, there is not such a thing as a non-compliant patient. It's a thing that we're writing a treatment plan that's never going to work for them. And it doesn't mean that the treatment plan is totally appropriate, but it's not going to work for this patient. And our role is to figure out how to remove those barriers. And so one of the ways is to come up with innovative ways that's acknowledging that no two patients are the same. And it's an incumbent on us to, if we're going to have this successful relationship, we've got to think differently about these encounters. So when they come into the clinic, we may only, the physician may only get 20 minutes, 30 minutes at best, but then it's a missed opportunity if that 30 minutes is not utilized in a way that's going to get them the care delivered in a way that's going to help them to have the very best outcome. In the hospital, it's the same way. We've got to start thinking with the end in mind, that in 5 to 7 days, every patient's going to go home. And we want them to go home equipped with the equipment they need, the medications they need, knowing who to call if something doesn't work right in the first couple of weeks, because we know it's probably not going to work right, and getting them comfortable with being able to call early and recognizing the signs that something's not right in this treatment plan when I get home. And so I really think the community health worker or the patient navigator approach is one way to do what you just said. And as an institution, I think we need to do more of that. And then I think we need to go into places like churches, barbershop, and we need to start going into other places talking about health, going to where patients live and work every day. Because when you're in crisis, that's not the time to teach people. And when you come to a busy clinic, that may not be the time. The time is to go out into the community and talk more about all of these topics that we know are important.
Thank you. Thank you so much. You answered one of the questions that was in the chat, and it related to what is your system, or what are all of our systems doing to reach the hard to reach? And patient navigators, community health workers, I know we have engaged with community health workers to help with social determinants of health, as well as teaching more about kidney disease. And in our case, we're partnering with multiple partners, in our case around the state, to develop a formal curriculum for community health workers that are going to be dealing with persons that have, kidney health challenges, so that in a special curriculum to help them to do that, because we do at the National Kidney Foundation of Illinois value and understand you really have to go to where the people are. And in fact, one of our signature program is our kidney mobile that goes around the state and provides, I know Milda's not, and provides screening for the purposes of early detection. We've had to send people 911 to the hospital. It's amazing what people are walking around with, blood pressures through the roof. And we have medical and clinical staff that help the persons that are being screened interpret those point of care tests. Because, testing people and handing them a piece of paper is not really helpful if they don't know what the results really mean, and referring them back to their primary care providers. So that going, as you indicated, going to where the people are and having that when it's not a crisis, it makes a real difference. You've had an opportunity in my career to work in ambulatory care, and totally appreciate why are you here today? You have from primary care standpoint, that 20 minutes, you have a care plan, and what are we going to do? So in, the impact of pre-visit planning, the plan in the visit and post-visit planning, which is where the community and the partnerships really can make a difference. One question that we received earlier, based off of a statement that you had made, Deborah, and it really applies, as we talk about health equity and the importance of it, DEI and health equity, is that you had made a statement and that an attendee wants to know a little bit more about the question of why healthcare systems, if not the why, or what has contributed to healthcare systems being designed with some level of inherent inequities. That you had mentioned earlier, and I think when you were going through as your roles and why you're interested in and why you're in the role you're in, maybe some examples may be helpful. I know we have ours, in the kidney world with the EGFR, and the impact on care and treatment, but are there other systemic type of inequities that have been inherited that I know you and your team help to work through?
Yeah, I mean, I think we can think in terms of generationally, people approach health in much different ways depending on your age. How we communicate with patients, we need to be sensitive to the age of the patient, not stereotyping, but we need to assess their access to a car. We need to assess their access to digital help. Do you have a cell phone? Do you have the internet? All of those things that, depending on your comfort level or depending on your access to things from an age perspective or a socioeconomic perspective, if we're not asking the right questions, we won't know. We will be going blind, or you can make an assumption, but until you start to assess those things, you will not know. Also, is setting up your structures to make sure it's inclusive. Your patient advisory committees, is it diverse in terms of age, race, gender? If you're not looking at that data, you will have blind spots because it is not inclusive. So you could be receiving not a broad enough spectrum of input from people. We do know the data is clear that if you're not looking at your physician staff or your nursing staff from the perspective of diversity, people have better outcomes when they're taken care of by people who look like them. Well, we know that takes a longer strategy to make that happen. So then you have to be focused on, how do I educate the team that I have to be curious, to understand that not all patients are the same, to understand the importance of every interaction, leaving the person feeling respected, the importance of developing a rapport with not only the patient, but the patient's family, and being able to recognize when you don't have that, because that's being self-aware. And so we do a lot of training on our core values. And you may think, well, what does core values have to do with health equity? It has everything to do with it, because it's the core of how you approach the delivery of healthcare. We added inclusivity as a core value because that means that our very nature is to recognize differences and to open up a safe space where everybody's communicating and respecting one another. We have a patient first core value, where if the patient comes first, you have to recognize differences. You have to lean into it. So just setting up core belief systems that's going to get to it, and then being committed to looking at outcomes from a demographic perspective, because no matter what your intent is, you may, if you don't look at the data, you may be missing outcome opportunities to improve. So it's really just approaching every aspect of the care delivery, trying to deliver the care in an inclusive way, but also recognizing it's going to take education and awareness training too.
Thank you very much. You know, you mentioned a point that I want to pivot over to Dr. Milda, because we know that you work very closely, Milda, with medical students. And when we talk about pipeline, and that is a longer term strategy, but it has to start at some point, and it has to be deliberate. And this medical school, all of the health, you know, all aspects of the professions, as well as training, as we indicated earlier, community health workers. But can you share in terms of what you have found, Milda, in working with the medical students and really working to try to develop that pipeline and that understanding and of the importance of equity, health equity?
Yeah, so I think as one, it is true. Research has shown that when patients are treated by a clinician that looks like them, they have better outcomes. It works for gender, it works for race, it works for language. So we want to increase the number of people who are in those roles. And so a lot of sort of pathway programs sort of just get students on campus at a medical center to say, oh, look at this. Here are people who are here who are looking like you. And this can be you, and hearing people's stories, but then also providing sort of support and coaching, because we know that getting into medical school is sort of there's some class-based advantages, let's say. And some of those advantages are historic. If no one in your family is a doctor, you don't know what you need. You don't know you need research. You don't maybe know that if you're working a job, you don't know that you need to have some patient contact. So just making sure that everybody knows what the requirements are and helping people to get that. So a lot of that starts before people even get to college. But then there are a lot of points of rescue, because people come in, they say, oh, I want to be a doctor, and then they get discouraged throughout college, by the medical, their school counselors, when they take the MCAT, when they apply, and it's so expensive, all of these things. But once they finally get on board, we can't just have clinicians who look like people, who look like the patients that we serve. It just, the numbers unfortunately don't match. And so another thing is educating all of our medical students to work with patients and not say, oh, if this patient is from this group, then they think this. If this patient is from this group, then they think this. Saying, here is history. This is why things are like this. And here are some questions that you can ask to get to know where your patient is coming from and to treat them respectfully. And so I think right now, and so it's front of mind, I'm one of the co-directors of a health equity, advocacy, and anti-racism course that is a required course for all of our first-year students. Most of them come with so much experience and knowledge, it just blows me away. But we all have blind spots. I have blind spots, they have blind spots, just that things they do or things that they would perpetuate just because they don't know or they haven't thought about it. And so we, sort of talk about racism and classism and sort of neighborhood barriers and, ableism and, so all of those things we need to teach our learners about that. And then they actually keep us honest, right? Like they say, ooh, why did you do that for this patient? Or, I think you misgendered this patient. And so I think it's getting people in the pathway, supporting them, but then everybody who walks through the door, who's going to go work in a community, who's interacting with some patient, making sure that they have the tools and the knowledge and the sensibility to take care of all of our patients, so that, hopefully the data won't show that you have better outcomes when somebody looks like you, because you can get sort of equal outcomes from all clinicians, is the hope.
So thank you very much. So Milda, we received a question more directed to you that says, as when people come to those that are able to have a primary care provider and they visit, are there questions they should be asking, even in those 20, 30 minutes, to make sure in terms, we know about knowing about their family history, but are there other questions that you have recommended that patients ask when they visit? Because you get in there and you just freeze up. All right. So any particular areas of insight into that?
Yeah, so I recommend that people go in with a list, a piece of paper. And Deborah mentioned community health workers, and I think that's terrific. But if you can't have that, if your system doesn't have that, maybe bring someone else with you. Your doctor's telling you this, your mind just completely goes blank. Have someone with you, or your notebook, so that you have your questions. And the things you should ask about are, what is the one thing I can do to improve my health before I see you next time? Or you can ask, what do these numbers mean? Or you can tell them, because we can look at the numbers, but we don't necessarily know, and sometimes don't ask some of these other things. And so I see someone, they look great, their blood pressure is great, their numbers look great, but they say that they're in a domestic violence situation. Or they say that, next month they won't have a place to stay. Those are things that we don't know, and that is going to affect your health, be much more impactful to your health than, maybe some things that I'm talking about protecting you in the long term. And so thinking about those things, telling us things that we should ask, but don't always ask, or if we do ask, answering honestly, so that we can then have a conversation. And we might not be the right person to help you, but we can connect you to someone who can. So I think knowing your numbers, talking about the problems that you're facing that may be a barrier, and then having some support so that you can sort of process, ask your questions, and then sort of, take note of those answers.
Thank you very much. One, I would say, culminating as a type question I'm going to ask both of you is, in a time when DEI, health equity, inclusion, belonging, policy, and resource allocations are being challenged on the national, regional, and local market stage, what nuggets of knowledge, that's a term we like, what nuggets of knowledge would you provide to guide sustainability of working toward and achieving health equity? Who do we need to be talking to? What are those in these, very challenging times? So, Deborah, I'm going to start with you.
Yeah, I think that's an important question for us to talk about today. And I think in healthcare, we're in a unique situation because, and we need to talk more about our responsibility to address health equity, and talk about it in terms of understanding there are regulatory reasons we have to do this work.
Got it.
CMS is requiring us. Joint Commission is requiring us. Our commitment to quality and patient safety requires us to do it. So I think we need to start there, because there are political reasons why it is absolutely the right thing to do. But for us to level set with everyone that this is not political, and it's also not optional, that it is our responsibility to do it, and we're regulated to do it. And so I like to start there with the conversation, because I think that helps us to get out of the realm of being political or or being misunderstood, let's just start there.
That's an excellent place to start. I know I'm getting I need to move, because this could be that question is a session in and of itself. But, I think with health equity is not a zero-sum game, which sometimes that can be a whole session in itself, which some people, sometimes that's a perception. And so with that question, Dr. Milda, in terms of just your top of mind thoughts as we close.
Yeah, I would say potentially framing your message so that people can hear you. Not everybody cares about health equity, but people care about quality of care, high quality care for all patients. That's not a DEI phrase. That's quality. Not everybody cares about health equity, but they care about cost. How can we reduce the long-term cost for patient care? And so you frame that message in that way. And so knowing what your goal is and knowing what their goals are, and seeing how you can meet them where they are.
Well, thank you very much. Thank you both. And thanks to all the attendees. I know that this is going to be posted through the Diversity MBA. We thank them again for this opportunity and wishing everyone, very excellent rest of your day.
Thank you so much.
Thank you.
Thank you so much.